Before we start with questions, I would like your really permission to address just a couple of questions from your colleagues from internet, because clearly our paper published in Neurology created a lot of hot questions, and I feel really, although we can't respond to internet, I feel very comfortable to use this forum and try to respond some of those questions. First, one of the questions was, how were our studies blinded? So we did the following. We instructed the subjects not to tell us if they are MS patients or patients with other diseases or healthy people. We include patients who had no disability at all. We include patients who had enormous disability but did not have MS. We used this ultrasound technologies who was not aware of symptoms of MS or other diseases, and they were all unaware of how many people will enter in the same group. So could have been 1 migraine patients or 150 migraine patients. Nobody knew that. In the phase 2, we are positioning subjects on the ultrasound chair by completely different personnel and covering all subjects up to the neck. And we definitely care about what will happen with those people who participate in our studies when we are going to unblind them and tell them their diagnosis. And I hope this will be very soon. Another question was how we determine the prevalence. So we determined prevalence in our study in 3 different ways, using just negative versus positive cases. There were borderline cases and which we didn't know whether they have or not have CCSVI, and I will tell you in a moment why. And those were put into the negative group. There was a lot of questions on internet why. And we also looked the people who had only 1 criteria. So what happened with these borderline cases? 52 cases resulted of 499 borderline because we could not determine the criteria number 2. Why? Because of the technical issues, or was not visualized, or there were artifacts, so we can't judge whether somebody has that criteria present or not. Now, I can tell you that this is not published, but we conducted many studies in the meantime, and we can say that criteria number 2, which is the reflux in the deep cerebral veins, is a very, in my opinion, questionable criteria, because in all reproducibility studies that we did between 2 very trained operators, there is a 50% chance for an error. And that's why instead of guessing what is there, we felt when we couldn't find it, we felt it's better not to guess, but not to assess this criteria. Why we put then these borderline people in the negative group? We didn't feel to put them as positive, and I think that we took the conservative approach, which is toward the null hypothesis, and put these 52 people as negative. That's why we provided the prevalence in 3 different ways to just look the negative and positive, and you know the numbers are changing 6% in total. So I don't think that there is such a huge polemic about that. Why we did include familial healthy controls? Because we wanted to understand whether brother, mother, sister, father, daughter of these MS patients have more risk for having CCSVI. We had 48 familial first-degree healthy controls and 115 non-familial healthy controls, and there was no difference between the 2 groups at all. And that's when we combined the 2 groups in 1 healthy control group to clearly increase the power of statistical analysis. Finally, we found that pediatric people were 50% positive, and these people were not at the first clinical attack. These were people already a couple of years in their disease. It has to be said that there were pediatric healthy controls, kids with 12 years old, and pediatric kids with other neurologic diseases who were CCSVI positive. So to call in question pediatric MS, first 50% have been negative, and second, there have been people, pediatric kids who also had CCSVI but did not have MS. The most important question is how do we interpret and why we did interpret our data in terms of causality versus association. And I think that Dr. Weinstock did an amazing job today to explain this topic, but I would just like to reinforce that by the prevalence data we have, 56% or 62% of MS patients and 22 to 25% of healthy controls, and also 45% of people with other neurologic diseases, we cannot think that CCSVI has a primary role in MS. Is CCSVI a result of MS? It cannot be excluded by our studies that CCSVI is contributor to MS progression. It cannot be excluded that CCSVI is a consequence of MS progression. And I specifically created this slide actually thanks to the advisory council yesterday who asked me to show this in a manner of a graph. So this graph, this is not my idea, it's the advisory council idea. So we plotted the CCSVI prevalence we found and the disease duration or age, and you can see almost a linear increase in a prevalence of CCSVI with disease progression. That is telling you that there might be more an acquired than present from the beginning. Now, whether MS is causing that or CCSVI is happening there because of something else, I'm not able to answer with our study that we did. But we need to acknowledge that there is definitely, increasing almost 3 times higher prevalence with 20 years of disease duration. And one thing to all people who will listen this, a scientist is a good scientist if he's open for suggestion and to change his mind. And my friend Elliot Froman from Dallas, Texas always said, a good scientist should always have a right to change his mind. And I'm reserving this right today in the future, respect to whoever we are going to find. But be aware that we will try always to report in whatever direction the science goes, the truth at the best of abilities that we have to interpret it. So I would like to have Adnan and Bianca here and to take some of your questions. There are some here.